Good morning. Today we will discussion about systemic disease of connective tissue with immunization. As a rule in literature, you can see as a name this collagenoses, rheumatic disease, because in this general complex of pathology present, including rheumatism, rheumatoid arthritis, systemically lupus erythematosus, scleroderma, dermatomyositis, bacterial osteoarthritis disease, and any other local pathology of connective tissue. Also, systemic disease of connective tissue or rheumatic disease. These are a group of chronic diseases characterized by systemic lesion of connective tissue and blood vessels. In their etiology, a significant role is played by clinically apparent or latent streptococcus infection, and the pathogenetic mechanism mainly consists in allergic reaction of delayed and immediate type. There develops progressive disorganization of connective tissue, a mucous edema, a fibrinoid edema and necrosis, cellular reaction of granulomatosis, and sclerosis. This pathological process was studied in first semester. Also, the pathogenesis of rheumatic disease is of single type. Every nosologic form has its characteristic peculiarity. In rheumatism, for instance, the synthesis factor is antibodies against the beta-hemolytic streptococcus of A type that have affinity to antigens of cardiac connective tissue. That is why rheumatism usually affects the patient's heart. Rheumatoid arthritis mainly affects the connective tissue of articular capsules. Important to the pathogenesis of the disease are the immune complex, where the antibodies are immunoglobulins of various types: immunoglobulin M, immunoglobulin G, immunoglobulin A. In systemic lupus erythematosus, the DNA metabolism is disturbed and antibodies are produced against the components of the nucleus and the cytoplasm: DNA, RNA, histones, nucleoproteins. This causes polymorphic change in many organs and tissues, but mainly in skin, vessels, kidneys, and heart. Systemic scleroderma is characterized by sclerotic and atrophic change of skin. The range of synthesis of collagen is considered to be a decisive factor for scleroderma development. Pericarditis nodosa is defined by a complex immune mechanism of arterial lesion of small and medium caliber, which leads to secondary transformation of internal organs. It is considered that the fibrinoid necrosis of middle cord of blood vessels causes the development of proliferative reaction of cells in the outer cord, which is followed by sclerosis and formation of nodules. Also, very important disease in this group is rheumatism. Rheumatism is a chronic disease with prevalent lesion of heart and blood vessels. Its progression is undulating periods of exacerbation alternate with remissions. Its development is associated with beta-hemolytic streptococcus of A type. However, rheumatism cannot be regarded as a simple streptococcal infection. Penetrated the body through tonsils, streptococcal release toxins and cause in the place of invasion cells destruction and inflammation that usually manifests itself in tonsillitis. The toxins and cell destruction products are the antigen against which antibodies are produced. By rheumatism present 4 stages of connective tissue disorganization and observed in the development of rheumatism: mucous edema, fibrinoid change, granulomatosis, and sclerosis. In this histological picture, you can see signs first stage or first change in connective tissue by rheumatism via formation mucous edema. This is surface and residue disorganization of connective tissue characterized by intensive metachromic reaction to glucose aminoglycans and gidation of basal substance. In center, you can see signs of mucous edema. In periphery, normal structure, normal stained in blue color. Also, mucous edema. For a clinician, it is important to know that this phase is reversible. Early diagnosis and beginning of treatment may bring complete recovery. Second stage, morphological change in connective tissue by rheumatism is fibrinoid change or swelling and necrosis. This is irreversible stage. They are characterized by homogenization of collagen fibers that get impregnated with plasma proteins, including fibrin. The stage of granulomatosis manifests itself morphologically inflammatory reaction of cells. It was first described in the form of nodular masses in heart stroma by Aschoff, 1904. And in 1930, Talalayev segmented out 3 phases in the development of rheumatic granuloma: alterative, exudative, proliferative, and sclerotic. Correlating them to clinical data, he showed that the whole cycle of granuloma development lasts for 4-6 months. Also, this picture presents any specific morphological signs formation of granuloma by rheumatism or granulomatosis. The alterative exudative phase is characterized by accumulation of macrophages around the fibrinoid necrosis focus, which transform into big cells with a hyperchromic nuclei in this. Such granuloma is called floriferous. It indicated an acute process going on. In the proliferative phase, the cells become elongated, they appear fibroblast, and the quantity of fibrinoid masses decreases. The further granuloma develops. It indicated the attenuation of process. In the phases of sclerosis, the fibroblast subtide the fibrinoid necrosis zone, and ergorophyll and collagen fibers are synthesized. The granuloma assumes the properties of the scar. This indicated the remission of the disease. In typical progression of rheumatism, it is the heart that is affected first and foremost. There develops endocarditis, myocarditis, less often pericarditis. Sometimes one can observe acute polyarthritis characterized by swelling of big joints, quick phases from one joint to another, and restoration of the function during remission. Chorea, erythema, annulary, formation of hypodermic nodes that is thought to be typical of rheumatism is relatively rare nowadays. Also, endocarditis. This first variant injury heart by rheumatism, and very often. According to localization, endocarditis can be valvular or valvulitis, chordal, and parietal. In most cases, the rheumatic process affected the mitral and the aortic valve. Depending upon the prevalent alterative or regenerative process, one distinguished between 4 types of rheumatic valvular endocarditis. In this picture, you can see signs, first variant rheumatic endocarditis, diffuse endocarditis. It characterized by diffuse mucous edema of connective tissue without endothelium lesion. In this macroscopically picture present signs injury endocardium by acute rheumatic fever. The small varicose vegetation seen along the closely line of this mitral valve. This watery vegetation every only a few millimeters and from along the line of valvular closely over areas of endocardial inflammation. Such varicose are too small to cause serious cardiac problems. In this picture, present signs acute varicose endocarditis. It defined by fibrinoid transformation of connective tissue and endothelium discoloration with accumulation in the places of lesion of thrombotic masses in the form of warts. This histological signs fibroblastic endocarditis that develops as a result of the above mentioned forms and is characterized by existence of newly formed connective tissue, emboli of blood vessels, and regeneration of epithelium. The valve is thickened and transformed by scar, which causes its deficiency acquired valvular disease. In this picture, present signs result rheumatic endocarditis via formation stenosis of mitral valve. These two signs of more stenosis of mitral valve. The heart has been sectioned to reveal the mitral valve as seen from above in the left atrium. The mitral valve demonstrates the typical fish mouth shape with chronic rheumatic scarring. Mitral valve is most often affected with rheumatic heart disease, followed by mitral and aortic together, then aortic alone, then mitral aortic, then tricuspid together. And this picture demonstrates variant Chordal endocarditis. In time, chronic rheumatic valvulitis may develop by organization of the acute endocardial inflammation along with fibrosis, as shown here affected the mitral valve. Note the shortened and thickened chorda tendinae. This picture histological signs recurrent varicose endocarditis. It characterized by recurrent disorganization of the newly formed connective tissue, endothelium lesion, and fibrin deposition due to sclerosis and hyalinosis of the valve. This process indicates a recurrent rheumatism attack. Next variant injury of heart by rheumatism is myocarditis. It is a content manifested of rheumatism. 3 forms of it are singled out. First, granulomatosis, characterized by presence of floriflower, fading, and sclerotic rheumatic granulomas in perivascular connective tissue. Second, diffuse exudative interstitial myocarditis, characterized by edema, hyperemia, and considerable infiltration of interstitium with lymphocytes, histiocytes, neutrophils, and eosinophils, and solitary Aschoff granulomas. And third variant myocarditis, focal exudative interstitial myocarditis, that manifests itself in slight focal infiltration of interstitium with lymphocytes, histiocytes, and neutrophils. Under favorable conditions, myocard develops into cardiosclerosis. This histological picture formation acute rheumatic carditis. Microscopically, acute rheumatic carditis is marked by a peculiar form of granulomas, granulomatosis inflammation with so-called Aschoff nodules, seen best in myocardium. These are centered in interstitium around vessels and shown here. The myocarditis may be severe enough to cause congestive heart failure. In this histological picture, we demonstrate structure Aschoff nodule. The most characteristic components is the Aschoff giant cell. Several appear here as large cells with two or more nuclei that have prominent nucleoli. Scattered inflammatory cells accompany them and can be mononuclear or occasionally neutrophils. This picture to demonstrate some histological signs of acute rheumatic carditis. Another peculiar cell seen with acute rheumatic carditis is the Cardiomyopathies. This is a long, thin cell with an enlarged nuclei. Pericarditis, third variant injury of heart. It is a sort of serous, fibrinous, or fibrinous exudative inflammation. It often ends with the formation of adhesions, obliteration of pericardial cavity, and calcification of the formed connective tissue may also occur stone heart. This scheme we demonstrate signs serous pericarditis. This diagram depicts the appearance of a serous pericarditis. The amount of inflammation is minimal, so no oxidate or fibrin occur. The dark stippled dots in the yellow fluid and on the epicardial surface represent scattered inflammatory cells. Serous pericarditis is marked by fluid collection. Rarely the fluid collection may be large enough to cause tamponade. And this macroscopically assigns serous pericarditis, where present accumulation serous exudate in clear of pericardium cavity. Fibrinous pericarditis. This diagram depicts the appearance of fibrinous pericarditis. The red-pink squiggly lines extending from the epicardial surface into the yellow fluid represent the strands of fibrin. This type of pericarditis is typical of uremia with renal failure, underlying myocardial infarction, and acute rheumatic carditis. This macroscopically picture presents signs fibrinous pericarditis. This is an example of fibrinous pericarditis. The surface appears roughened from the normal glistening appearance by the strands of pink tan fibrin. Histological signs: fibrinous pericarditis. Microscopically, the pericardial surface shows strands of pink fibrin extending outwards. There is underlying inflammation. Eventually, the fibrin can be organized and cleared, though sometimes adhesion may remain. Rheumatic carditis and pancarditis. The combination of endo and myocarditis is referred to as rheumatic carditis, and that of endo, myo, and pericarditis as rheumatic pancarditis. Vasculitis. Rheumatism has systemic nature and is observed in all organs and tissues. Capillary permeability increased drastically. It manifests itself clinically in nodular erythema. It often occurs that skin capillaries are rapid in pericytes moved, and endothelium is in the state of proliferation. In the end, there develops sclerosis around capillaries with the formation of rheumatic nodules. Polyarthritis. Polyarthritis by rheumatism is usually serofibrinous. Articular cartilage is not damaged, so there can be no articular deformation. Juvenile chorea. Juvenile chorea is a cerebral form of rheumatism. It occurs more often in children. Because of vasculitis, they develop dystrophic change of nerve cells in the brain, as well as distraction focuses and hemorrhages that are morphological basis of clinical presentations. Complications by rheumatism are connected in most cases with heart lesion, valvular defects and embolism in varicose endocarditis, internal infarcts, encephalomalacia, limb gangrene, commissurus and obliteration of pericardial cavity. The most frequent cause of death of rheumatism is the composite valvular defect and thromboembolic complication. In this picture, we demonstrate science complication by rheumatism, where formation decompensate valvular defect, and then in lung present science formation gemosiderosis, brown cells. This is macrophages, including gemosiderin. Rheumatoid arthritis. Next disease by this pathology. It is a chronic disease based on progressive disorganization of connective tissue of synovial membranes and articular cartilage. It's very important, attention. A present injury articular cartilage. Its characteristic feature is the development of non-suppurative proliferative synovitis followed by articular deformation. Attention. Outcome: rheumatoid arthritis, formation, articular deformation. By rheumatism, such complication absent. Also, rheumatoid arthritis often causes damage to skin, blood vessels, heart, lungs, muscles, and other organs and tissues. It affected mainly women. The cause of the disease is unknown, but one point out genetic susceptibility to autoimmune reaction to collagen of type 2. T lymphocytes releasing inflammatory mediators and lytic cytokines that destroy joints. Microbial infection, especially virus, is often the starting point for the disease. The body produces antibodies to its own immunoglobulin G, which is a rheumatoid factor. Morphological change mainly manifests themselves in the lesion of musculoskeletal system, Synovitis develops of three stages. First stage of synovitis is characterized by edema of synovial membrane with the development of disorganization of connective tissue, mucoid and fibrinoid swelling, fibrinoid necrosis. The willy necrotizes and 3 develops rice body. There are signs of inflammatory reaction of cells in tissues. This histological signs formation rheumatoid arthritis. This is a synovium in the rheumatoid arthritis. There is chronic inflammation with lymphocytes and plasma cells that produce the blue areas beneath the nodular proliferation. This panus is destructive and produces erosion of the articular cartilage, eventually destroyed the joint. The second stage manifests itself in the growth of villi and proliferation of synovitis, in inflammatory cellular infiltration, in the formation of granulation tissue on the joint surface, erosion of articular cartilage, exposure of bone and epiphysis in osteoporosis. The granulation tissue narrows the joint space, decreases articular mobility, and causes luxation and subluxations. The third stage manifests itself in fibrous and bony ankylosis and develops after long progression of the disease. It is defined the complete articular immobility, the formation of rheumatoid nodules around joints with signs of destructive change in connective tissue. This macroscopically signs injury of joint by rheumatoid arthritis. The prominent ulnar deviation of the hands and swan neck deformity of the fingers seen here is due to rheumatoid arthritis. This autoimmune disease leads to synovial proliferation with inflammation and joint destruction, typically in a symmetrical pattern involve small joints of hands and feet, followed by wrists, ankles, elbows, and knees. Rheumatoid factor can be indefinite serologically in most but not all rheumatoid arthritis patients. Also, attention, you must remember, by rheumatoid arthritis present injury small joints, present signs symmetric injury. By rheumatism present injury large joints and absent deformation. Visceral manifestations of rheumatoid arthritis. The main visceral manifestation of rheumatoid arthritis are polyserositis vasculitis in lungs and heart with disorganization of connective tissue, and inflammatory cellular infiltration with lymphocytes, plasmacytes, and histiocytes. The heart may be affected by endocarditis with the development of valvular disease, the lungs by pneumosclerosis. Attention, in this picture present formation rheumatoid arthritis, nodule by rheumatoid arthritis. Sometimes persons with rheumatoid arthritis have rheumatoid nodules form in subcutaneous localization at pressure points such as an elbow shown here. Rheumatoid nodules may also appear viscerally, such as on the pleura of the lung. These histological signs structure rheumatoid nodule. Here is a rheumatoid nodule. Such nodules are seen in patient with severe rheumatoid arthritis and appear beneath the skin of a bony prominence such as the elbow. They can occasionally appear in visceral organs. There is a central area of fibrinoid necrosis surrounded by palisandine epithelioid macrophages and other mononuclear cells. One of the complications is renal amyloidosis with the development of uremia, which is often the cause of patient death. Next disease in this group is Bechterew or Strumpel's disease or pocketback, or ankylosing spondylitis. Rheumatoid spondylitis is a chronic rheumatic disease characterized by the lesion of articular and ligamentous apparatus of spine that ends with its immobility. Etiology and pathogenesis of Bechterew or Strumpel's disease. It is etiology and pathogenesis. The main role is played by infection and allergic factors, spinal trauma, and hereditary. More often, it affected men. Pathological anatomy is characterized by the development of destructive inflammatory change in the tissues of small spinal joints with the destruction of articular cartilage and the development of bony ankylosis. Similar transformation develop in intervertebral discs. The spine becomes complete immobility. Damage internal organs. It also damages internal organs, aorta, heart, lungs. There develops renal amyloidosis, which is often the cause of death. Systemic lupus erythematosus or disease of Libman-Sacks. It is a systemic disease marked by autoimmunization that has acute or chronic progression and is characterized by the lesion of skin, vessels, and kidneys. More often, it affected young women. Etiology. The cause of the disease is unknown. Non-specific provoking factors are ultraviolet radiation and pregnancy. The disease may develop after a viral infection. Hereditary factors play an important role too. Pathogenesis. In its pathogenesis, a significant role is played by the imbalance of the function of T suppressor and T helpers with the formation of multiply organ antibodies, lupus factor, anti-nuclear antibodies. The pathological anatomy is characterized by the development of fibrinoid change in the walls of microcirculation vessels with the formation of vasculitis that ends with secondary ischemic change in organs in the form of dystrophy and necrosis. Affected of the skin. Skin is affected by erythema, red butterfly, due to proliferative destructive vasculitis in the derma, edema, and focal perivascular lymphocytic infiltration. Kidneys are affected by lupus glomerulonephritis or mesangial-proliferative glomerulonephritis. A characteristic peculiarity is the deposition of immune complex and capillary thickening in the form of via loops. Fibrinoid necrosis focuses gematoxylin bodies, hyalin thrombi. Glomerulonephritis results in contraction of kidneys and development of renal insufficiency, which is often the cause of patient's death. Heart. By lupus erythematosus, injury is affected by non-bacterial varicose Libman-Sacks endocarditis, where hematoxylin bodies can be found in necrosis focuses. In contrast to rheumatism, no mucoid or fibrinoid intumescence can be observed. This macroscopically signs formation Libman-Sacks endocarditis by lupus erythematosus. Here are flat, pale, then spreading vegetation over the mitral valve surface and even on the Chordal tendons. Though this vegetation that can be on any valve or even on endocardial surface are considered with. This vegetation appears in about 4% of systemic lupus erythematosus patients and rarely cause problems because they are not large and rarely embolize. Note also the thickened, shortened, and fused Chordal tendinae that represent remote rheumatic heart disease. In spleen, one can find periarterial bulbous sclerosis. Among complications and cause of death of systemic lupus erythematosus, one should highlight lupus nephritis and the development of renal insufficiency. Systemic scleroderma is defined by the development of diffuse sclerosis and hyalinosis of connective tissue in various organs and tissues. The etiology and pathogenesis is unknown. Important the disease development are viral infections and hereditary factors with autoimmunization. Pathological anatomy. Major change develop in heart, kidneys, gastrointestinal tract, blood vessels, and skin. In the heart, one can observe sclerosis and contraction of mitral valve cusps, subendocardial cardiosclerosis with the development of cardiovascular collapse, sclerodermic heart. In coronary vessels, one can often find concentric sclerosis and hyalinosis. Around vessels, there is inflammatory infiltration with lymphocytes, macrophages, and plasmatic cells. Skin is affected by diffuse or focal epidermal atrophy, sclerotic transformation, and hyalinosis of connective tissue. In dermal vessels, one can observe vasculitis and later reduction of blood stream. Due to insufficient vascularization, their appearance, necrosis, and exuration focuses in the skin. The later becomes dense with focuses of hyperpigmentation and hemangiostasis. The face becomes mask-like. In kidney, there develops progressive vasculitis, concentric thickening of interlobular arteries, their thrombosis, cortical necrosis, and infarcts, parenchymal sclerosis with development of renal insufficiency. In lung, one can observe carnification due to diffuse fibrosis, thickening of alveolar septa, arteriolar sclerosis. In gastrointestinal tract, one can observe sclerotic transformation of submucous and muscular layer, swallowing and absorption derangement, slowing down of motility, development of cachexia. Next disease, dermatomyositis, is characterized by the lesion of transferal striated muscula and less by the of non-striated musculars. More often, it affected skeletal, pharyngeal, laryngeal, ocular, and diaphragmatic muscles. Muscular atrophic and dystrophic change, low the striation, the fermentative activity and glycogen supply decrease. Sometimes coagulation necrosis occur. muscular are gradually substituted by connective tissue and fat masses. In the heart, one can observe dystrophy of cardiomyositis, intermediate myocarditis with productive vasculitis, edema of intercellular substance, infiltration with lymphocytes, macrophages, and plasmatic cells. The process ends with diffuse cardiosclerosis and atrophy of cardiomyositis. In lung, alveolar septa are thickened. In gastrointestinal tract, one can observe atrophic and dystrophic transformation of muscular cells, perivascular lymphomacrophage infiltrations, sclerosis of mucus and submucous layer. Other organs undergo inflammatory and sclerotic change. Cardiomyopathies, dilated or congestive. All four chambers are dilated, and there is also hypertrophy. The most common cause is chronic alcoholism, through some may be the end stage of remote viral myocarditis. Idiopathic or dilated cardiomyopathy, this is macroscopically sized. He is a large, dilating left ventricular, typical of a dilated or congestive cardiomyopathy. Many of these have no known etiology, while others may be associated with chronic alcoholism. The heart is very enlarged and flabby. Hypertrophic myocardiopathy. The most common form idiopathic hypertrophic subaortic stenosis result from asymmetric interventricular septal hypertrophy resulting of left ventricular outflow obstruction. This is signs of hypertrophic cardiomyopathy. There is marked left ventricular hypertrophy with asymmetric bulging of very large intraventricular septa into the left ventricular chamber. Restrictive cardiomyopathy. The myocardium is infiltrated with a material that results in impaired ventricular filling. The most common cause the amyloidosis and gammochromatosis. This is histological signs myocardiopathy. This section of myocardium demonstrates amorphous deposits of pale pink material between myocardial fibers. This is characteristic for amyloid. Amyloidosis is a cause for infiltrative or restrictive cardiomyopathy. This is macroscopically signs of cardiomyopathy. This very large heart has a globoid shape because all of the chambers are dilated. It left very flabby, and the myocardium was poorly contractile. This term is used to denote condition in which the myocardium function poorly, and the heart is large and dilated, but there is no specific histological finding. This microscopically, the heart in cardiomyopathy demonstrates hypertrophy of myocardial fibers, which also prominent dark nuclei, along with interstitial fibrosis. Thank you very much.